We are now facing a very new and exciting time in London. We have an anonymous donor that has given us some very strong funds, not to the walk, but to hematology, myeloma. And we are spearheading now minimal residual disease assessment for our patients. So we bought a new machine, a new instrument that will be really paramount and is very novel in diagnosing what we call minimal residual disease, which is a subject that we're not going to be going through now. We do have partnership with a few other centers around the world, so we're getting our name out there, doing quality research, and part of this is utilizing sometimes the Walk of Champions funds. So I would like to let you know that we are working on this. We have a database that's a pan-Canadian database that collects information on patients with multiple myeloma, and we have since 2016, if I'm not mistaken, or probably a little bit before that, we have 21 published articles. Yes, and we have in London 1,000 patients contributing to this 10,000 patient database. So if you compare small little town, small little center with Toronto, Vancouver, like we do a really great job in, getting patients information into the database and producing high quality research that Health Canada acknowledges, CADIT acknowledges. So this is really, really important, and thank you, because you are definitely a direct part of all of this in a direct way or in an indirect way as well. So thank you so much. So today, as Lisa was mentioning, I'm substituting Dr. Barji. The talk is really small. I have just a handful of slides, and I really wanted it to be interactive. I would like your questions to come up, and then we can discuss, because the question is, how do I interpret my blood work results? So this pertains a lot to your questions on the day-to-day assessment, right, of your results. So please feel free to chime in anytime. We'll see. Yeah. Thank you.
Is that too dark?
That's too dark, right? Everybody's gonna fall asleep again. This one is better, right? It's better for you guys to see, right? Yeah, there will be sometimes. Yeah, I should have put it a little bit bigger, but anyways, we'll try it. We'll try it. So if you don't mind passing the next one. So before we start about blood work discussion, I wanted to show you this table. This is a table that many of you have seen, maybe not all of you, because there are a lot of new people here today, but I have shown this table many different places, because this is a summary of what the spectrum of what we call plasma cell dyscrasia is. The most known plasma cell dyscrasia disorder is multiple myeloma, but plasma cell dyscrasias are a family of disorders. So I'm putting here the most common ones for you. So every patient with multiple myeloma starts in a pre-myeloma phase called MGUS. MGUS is a huge name that stands for monoclonal gammopathy of undetermined significance. So it's good because it's a very good name, but it has not a lot of relevance in your day-to-day living, because it's a completely asymptomatic and it's not a cancerous stage, it's a pre-cancer stage. So everybody that has myeloma, one day, many years prior to their diagnosis, they went through this MGUS stage, which in a lot of cases goes silently, because it doesn't give you symptoms. So if you don't have specific blood tests or urine tests showing that you have an abnormal protein, you will go 10, 15, 30 years without knowing, until one day you have multiple myeloma, okay? So about 8% of the population, 75 years of age or older, has MGUS, and a lot of them don't know it, okay? So we see no organ damage. So when I say organ damage means bone problems, kidney problems, or having anemia, which many of you may know what it is, and if you don't, I'm happy to explain whenever we're talking about blood work. Bone marrow, when we do the bone marrow test, if we do a bone marrow test in a patient with MGUS, there is less than 10% of abnormal myeloma cells in the bone marrow, okay? And then we only need to monitor once every year or every couple of years, or not to monitor at all, depending on the type of MGUS that the person has. So this is the phase number one. The second phase is the asymptomatic myeloma or smoldering myeloma. In this case, this is almost the same as MGUS, but the difference is that you have more than 10% of abnormal cells in the bone marrow. So this patient, even though this patient is still asymptomatic from a myeloma standpoint, this patient deserves a little bit of more of watchful eyes on him or her, because there is a higher risk of development into overt multiple myeloma or symptomatic multiple myeloma. So instead of monitoring every year, for instance, we follow every 3-4 months depending. Okay, so there are certain criteria that we follow that is in our guidelines, that we, assess what the risks are, and then we decide based on that at what time intervals that patient needs to be followed. So that's smoldering. And then we have the true myeloma. So the true myeloma is the patient that requires therapy. So this is the patient that definitely has, in the vast majority of time, more than 10% or 10% or more of abnormal cells in the marrow, and may have calcium problems or anemia or recurrent infections, bone problems, kidney problems. So that's the patient that requires to start treatment for multiple myeloma. The very end there in red is plasma cell leukemia that you probably have not heard of. Have anybody heard of plasma cell leukemia? Yeah, so plasma cell leukemia is a very acute, aggressive form of multiple myeloma, where the bone marrow of the patient produces a lot of abnormal plasma cells. Plasma cells are the myeloma cells, so they produce a lot of those cells, and those cells are so abnormal that they're able to survive in the bloodstream. The vast majority of time, the myeloma cell doesn't survive anywhere else but inside the bone, in the bone marrow. So in the plasma cell leukemia, the cells are so abnormal that they do survive elsewhere, and they're circulating in the blood, and this is a medical emergency where we need to admit the patient right away and start very aggressive treatment, like if they had an acute leukemia. So this is called plasma cell leukemia. Okay, thankfully this is not what we see on a day-to-day basis. So I just wanted to give you that little spiel about what we have, right, in terms of the spectrum of multiple myeloma. And then what differentiates myeloma from smoldering myeloma and MGUS, that you all know now what it is, right, is CRAB. So the CRAB features that I was talking to you without mentioning that it was CRAB is the calcium elevation, the renal insufficiency or kidney dysfunction that happens because of myeloma, anemia, which is the decrease in your red blood cell in the pigment that gives the red color to the blood, and bony disease, which are the bony disease of myeloma is typical, right, of multiple myeloma. So we call it CRAB. And then how frequent do we have CRAB? So with each one of them happens more frequently or less frequently. So if you see here, anemia happens in about 70% of patients that present with it at diagnosis. Then we have the bone lesions that happen in about 60% of patients, and of those, 60% will have bone pain. It's very common that we see patients with bone pain, right? So more than half of the patients will have bone pain. Renal insufficiency or kidney disease, that's acute, happens in about 20% of patients. And hypercalcemia or elevated calcium in the blood happens in about 13% of patients, so it's not so normal. It is directly associated to the level of bone destruction by the myeloma cells, because the myeloma cells will then sort of eat up the bone, and the calcium that is deposited in the bones, then goes into the blood circulation. So that is a surrogate of bone disease in multiple myeloma as well. So that's what we have there as the most common pictures. We can go to the next one.
No.
Any questions so far? All good? Okay. So then we're going to start talking about blood work. So I don't want to be here just simply talking about blood work. What questions do you have with, when I say blood work, I'm talking about this one specifically, CBC, or complete blood count. Those are our cells, our blood cells. So do you know which cells our blood is composed of? So yeah, speak up.
These are white.
White cells, red.
The hemoglobin is about a combination of stuff.
Which combination?
The hemoglobin.
Hemoglobin,
That,
yes.
and then there's the neutrophils.
Neutrophils, there we go. Platelets, yes. So for you guys, these are the major ones, right? So the white cells, the hemoglobin, the platelets, and the neutrophils. At least this is what you all write down in your notebooks, right, when you come, because you know that they're important to assess whether you are at certain risks, right? So the platelets are sticky cells, very small little cells that are in our blood, and their function is to cause the blood to clot so that we don't bleed to death, right, when we have a cut. So our platelets have that function. The white cells is an army, actually. So WBC is white blood cell that you can see up there. So that's an army of cells, and each one of those cells have a function, just like being in the army. So you have like from, you know, the most primary soldier to the general, right? So each one of them will have a function to protect our body against any foreign organism. So it could be a bacteria, it could be a mold, it could be a virus, it could be a cancer cell, it could be a chemical that we were exposed to. So our white cells will be working to make sure that our body is protected against any invaders, okay, unwanted invaders. In multiple myeloma, the white cells can be low because of treatment. So vast majority of time when you see that your white cells are low, it's because of a side effect of the treatment you're taking. But sometimes when you are diagnosed, because if your bone marrow is so full of myeloma cells, let's say 90% of your bone marrow is myeloma cells, then you won't have room for your normal white cells. You won't have room for your normal red cells or your platelets. So we see that the counts go down. So if you see here, this white cell, I think that if we click, it will show some.
Okay.
Yes, so instead of talking about the white cell first, so here we have the hemoglobin. So the hemoglobin is what gives the color of our red blood cells, and the hemoglobin is responsible for transporting oxygen in the blood, okay? So the hemoglobin, these are American metrics, so we use European metric. So instead of stating 10.1 grams per deciliter, in Canada we use 101 grams per liter. So it's a little bit different, but this still serves the purpose of an example. So we have a hemoglobin here that's higher than the cutoff of normality. So that person has anemia, right? So a lot of people think that, oh, you're anemic, you need iron. Yes, many times you do need iron, but in other circumstances you don't, because your iron is great. The only reason why your hemoglobin is low is, for instance, because of the treatment that you're taking. And what do we do about it? It depends. If it's a severe anemia, if it's a chronic anemia, acute anemia, you may have had a trauma and maybe you emerge with an acute blood loss. So all of these things are different, right? So we manage them in a different way. The white cells are the army of defenders, right, of our body. And you see that this one is quite low, so 1.3, where the norm is 4.4 up to 11. So this could be for a variety of reasons as well. And in most cases, in myeloma associated to treatment. So treatment adverse event. here, down here, we have the platelets. If you click on again, please, Lisa. The platelets are quite low. They're normal 150 to 400, and this one here is 29. Okay, so that you can see that this blood work here shows the results of a person that has low levels of the three major segments in our blood cells. Okay, so we can move on. Thank you. Here we have more examples, so it's okay that it's okay to leave it like that, because these are more blood cell count. It's a little bit blurry, but I wanted to show you the neutrophils that are here. So the neutrophils here, this is the percentage. In London, at LHSC, we don't tend to use the percentage. We use the absolute count, and the absolute count in this example is here. So this person has 3.1, normal 2 to 8. So what does this mean? It means that of all white blood cells that this person has at 5.4, 3.1, where is it? 3.1 is neutrophil. Okay, so that's what it means. And then, where's the other two? So the other two are scattered here. These are other white cells, so other cells that are part of our army. And then they're discriminated. So your blood work shows this. This is a real blood work of one of our patients. So this is an example of what we see in our computer when you guys come to see us. So this is the white cell, so quite low, 0.8. Hemoglobin here is 105, whereas the normal is usually here 135 to 180. And then the platelets are very low too, 119. They should be between 150 and 400. And here 0.7, the neutrophil count, we want it to be between usually above 2, right? Usually that's what we target. And then I put for you here, because many times you want to know, oh, my neutrophils are low, what do I do about it? How worried should I be because of getting an infection? Do I need to be masking myself all the time? So those types of concerns that the patients may have, right, when they come to clinic and they observe their blood work. So we call low neutrophil count, we call neutropenia. We call it neutropenia. So a mild neutropenia is, you can see here, if you have between 1 and 1.5. So normal is 2. Anything between 1.5 and 2 we still consider fairly normal. But if it's between 1 and 1.5, we consider it normal. Moderate between 0.5 and 1. And anything that's below 0.5 we consider as severe. So the severe is a higher risk of infection. And then it goes exponentially less as you are closer to normal levels. So in multiple myeloma, sometimes what we do is we either, if you are on treatment and this is because of treatment, we either modify your doses, or we give a larger interval in between cycles, or we can give a medication that's an injection that's given in your stomach or under your arm, filgrastim or Neupogen. Or there's something called pegfilgrastim that we can also give, and those can help to boost up a little bit these numbers for you. Okay? Questions about that? No? I thought I had a lot of questions in the blood work. Lisa, no question?
No.
No? Okay.
Oops, I don't know.
We can keep going.
Okay.
All right.
Oh, sorry.
So in this one I'm just showing the most common myeloma drugs that can cause abnormalities in the blood work. So those are the ones. And then we can move on to the next one. So then we're talking about the kidney function. So our kidneys, do you know what the kidneys work for? What is their function?
Filter the lungs.
Exactly. So they filter everything we drink. So one thing that the kidneys love, water. Sorry. So sometimes we will have patients where the doctor says, well, you need to reduce your water intake. There are very specific reasons when somebody needs to have a decrease in water intake. But most of the time in multiple myeloma, we want you to, just drink water. Or can I drink pop? Can I drink juice? I love, ice cream, soup, all good, but water is a must for your kidney. So always remember to have your bottle of water with you and make sure you're drenching your kidneys. That's what makes them happy and healthier, okay? In myeloma, the kidneys can suffer very easily, and the reason why they can suffer is very simplistically speaking here with you. We have the myeloma protein. The myeloma protein, doesn't matter if it's bigger or smaller, everything we eat and drink goes through the liver and goes through the kidneys. If the molecule is too large, or if the molecule is in a lot of quantity, like what we have in high burden of multiple myeloma, the kidneys cannot filter. So in these two pink areas here, those are your arteries and your veins that go into the kidneys to be filtered. And there is so you can have the myeloma protein that passes here, and if there's too many of it, it will clog certain very small, delicate areas of the kidneys, and then the kidneys won't be filtering well. They will suffer, and then you have what we call acute or chronic kidney injury, okay? So that's one thing. Now, when we look after that is done, sometimes patients recover totally or partially, and sometimes our kidneys are just getting older as we are getting older, right? So my daughter was asking me yesterday, we were watching a movie, very nice movie about a man that was a baseball coach of a little league team. It's a real story. I forgot the name. It's something believe. And he had cancer. He had melanoma, not myeloma. He had melanoma, and he ended up dying. And then my daughter came to me and asked, "Mom, why do older people have cancer?" So I was explaining to her, well, we are getting old as a car gets old, right? So a car, we get out of the store, brand new, great, no noise, everything blinking, right? But then with the passing of years, the car gets older, all the engines start to make noises and things like that. We are the same. So as we get older, our cells also get older, right? So the biological clock that before was like really good, like an iPhone 16, is now working as an iPhone 2. So, you know, things go wrong. And once the cells start to go wrong, then they can become cancerous. And the immune system that is supposed to be healthy enough to fight any cancer cells that show up, that pop up in our system, in our body, the immune system is also older and doesn't capture that. So this is one of the reasons why we develop the various different types of cancer, right? So one of the things that happen with our kidneys is as we're getting older, they also lose a little bit the ability of filtering as good as what they used to. So sometimes you're perfectly healthy, but then you go to the doctor and the doctor comes to you and says, well, your kidney function is only 60% or is only 50%. You still live normally, but it is lower than when you were 30 years old. And it's now because you're 78. You know what I mean? So that's what happens, generally speaking, to all of us. And in multiple myeloma, because there is an excess of protein production, which is the myeloma protein, then that can take a toll on the kidneys even more. So there is a specific protein called creatinine, and creatinine is the result of the breakdown of our muscles. So our muscular activity produces creatinine. And creatinine is the surrogate marker of kidney function. So we're always looking into your creatinine. So when you ask, oh, how's my kidney function going, doctor? I'm gonna be looking at your creatinine, and I can make a calculation with a little formula that has to do with your sex and your age and your weight, and make sure how well your kidneys are functioning in terms of proportion. Yes?
Is that tied in with the GFR test?
That's right, that's the GFR as well. So the GFR is actually a little bit more accurate than creatinine clearance, but those are both little formulas that we use to assess the percentage, let's say it this way, that your kidneys, what percentage is your kidney functioning with, okay, yeah.
seems to be a lot of debate about the amount of water we actually consume in a day. Can we look at, for instance, color of urine? Could that be an indicator for us?
It is an indicator for sure. So if you have a very strong yellow urine, it means you're dehydrated, so you need to drink more. And then the more translucent and transparent, I should say, like, or colorless your urine is, the more water you're drinking. Yeah, so a very light yellow, almost colorless is the ideal.
Which is far better than just saying, drink 10 glasses of water
That's right.
in a day.
Yeah, that's right. Yeah, sometimes that's what we should target. Yeah, like look at the color of your urine. One important thing, if you're taking vitamin B12, it will make your urine bright yellow, like sunlight color. So it doesn't mean you're dehydrated or there's something going wrong in the urine. This almost artificial color, artificial yellow, very bright, is because of the vitamin B. Yeah.
Is the intensity of yellow different for male and female?
Not that I know of. Yeah, not that I know of. But it's, yeah, like the strong, more golden yellow, that means that the urine is very concentrated. Yeah. Okay. So that's what we're trying to avoid. And when we look at the creatinine, by measuring the creatinine, we have an idea of how well the kidney function of that person is going or not. Okay, so we measure that every time you come to clinic to be assessed. Next one. Yeah. Oh yeah,
Oh.
it's just a funny little cartoon.
Funny
Yeah,
little guy.
that's okay. So, patients with decreased renal function may require dose reductions in certain types of medications that they take specifically from a myeloma standpoint, right? Obviously, there are other medications like blood pressure medications that need to be titrated depending on the kidney function, but those are very commonly affected or they affect the kidney function. And we always do some dose reductions and adjustments to make sure that you're getting a dose for treatment of myeloma that's appropriate for that kidney function so that you don't have an extrapolation in your side effects. And then the calcium we were talking about before. So the calcium is in our bones, right? So it's the largest reservoir of calcium in our body is in our bones. And we also know that inside of our bones, that's when we produce our plasma cells, which can be normal and will produce antibodies against viruses, bacteria, etc. Or they can be myelomatous, so abnormal antibodies. They all come from inside the bone marrow. And in the crest of the bone, that's where the calcium lies. And this is the calcium that we lose when there is myeloma disease, bone disease. So as I was talking to you, if we have a high calcium, that means very likely abnormal bone in that patient. So I will show you a few examples. It's a little bit of a hardcore slide, the next slide. So if you want to, we can pass quickly. But I have X-rays showing bone lesions. Do you guys want to see or prefer not? Yeah. Okay. So this is very brutal here, right? So very big. So you can see if you look here, this is the skull of the person. This is the profile. And then you can see that there are almost parts missing here of the crest of the bone. Those are bone lesions. All these black holes here, like punched out, they're all myeloma lesions, meaning that in those areas, the calcium was literally eaten up by the presence of the myeloma cell in the bone marrow that's underneath that bone cap. So there's another one here showing, this is a little bit darker, but these arrows show a lot of all of those dark spots. This is the pelvis of a patient, so it should always be whitish in color, but there are lots of small round dark spots. Those are bone lesions as well, and those are big ones. And this is an MRI picture showing, so the MRI doesn't necessarily show well bone lesions, but it shows infiltration of the bone marrow inside the bone. So there are some when you see the arrows there are certain dark and other certain lighter spots that will show either absence of bone or actually evidence of abnormal cells inside the bone marrow, which in this case pertain to multiple myeloma. And there's another one. Yeah, this is just another, it's a CT scan showing a vision of the skull that would be like this. So you're looking, like if you cut the person's head like this and you're seeing what's in there. So you see this would be the area of the brain. And here is all the bony area. And you can see the holes here, like the punched out that you saw in the x-ray. So very similar. So a bunch of them here. Yeah. It's interesting, right? It's terrible, but interesting. Yeah, yeah. And then here we have the myeloma protein. So the myeloma protein that we always talk about, what is it? Any takers? No? Okay, so we have myriad or myriad, I don't never know how to say it, of proteins in our blood. And the proteins usually, they have very specific functions. They don't do dual functions. They have that one and they go, then they only do that all the time, right? And our body is mostly composed of water and proteins. And in the case of multiple myeloma, we're talking about a specific area of proteins that are called globulins. Globulins because they tend to be more round. And in the gamma of globulins, we have different proteins. So we have alpha globulins, we have beta globulins, and we have gamma globulins. The gamma globulins are our antibodies. So we have several different antibodies. And we know that multiple myeloma exists because one plasma cell becomes myelomatous and starts producing abnormal or dysfunctional parts of antibodies, right? And then those antibodies that have no purpose circulate around the blood, cause damage in the marrow, cause damage to the kidneys, etc., right? So this is the graph of a person that had a test called protein electrophoresis. Could be done from the blood, which we call serum protein electrophoresis, or urine. And it will show here, especially in the serum, this is an example of serum, we have albumin, which gives us a peak, which is the most concentrated protein in the blood, in the blood of any body. And here we have all the globulins. The antibodies are the gamma component, okay, so they're here. When there is myeloma, instead of you having curvy wave like this, you have a spike, you have a peak. Similar, for instance, in this case to albumin. So when this has a peak like this, that raises the concern that, well, maybe there is a myeloma protein in there because it's not normal, because what we see is usually a curve that has a large base and not a spike with a narrow base. So then we continue to work around that to identify what protein that is. And then it shows us monoclonal. If it's a monoclonal protein, then that's a myelomatous protein, meaning that one cell is giving rise to cells that are exactly like the initial one, and those groups, that group of cells is producing one type of abnormal protein. And then I'll explain to you what that is, but sometimes you can come and say, well, but I have 2 proteins, or I have 3 proteins, different proteins in my myeloma. True, because one abnormal cell may produce more than one abnormal protein, or you may have 2 different myeloma clones working together, each one producing a different protein. Is that understood? Or confusing? Yeah, that's okay? Yeah? Okay. So this is another example here of blood work that we have in our hospital. So I will go over, do you guys want to go over what it means? Yeah? No? No, Robert doesn't want it. It's not your blood work, or maybe it is. Okay, so here I'm giving you examples of the gamma globulin. So Lisa, do you mind to go back?
Go back one? Yeah.
So here, when I say, well, when you don't have the spike, it means that everything is normal, right? So you have this more wavy here, curve here with a large base. So this is what I mean. Next one, please.
Okay.
Next slide, please. So you see here IgG, IgA, IgM. So these are antibodies that are normal, but they also contain our myeloma component. So here's the myeloma. So you can see this is here IgG. It's in green, 21.9 with an H, which means it's high. So IgG usually, depending on the kit that you use, goes up to 14 or 16 at the most. So if it's 21.9, it's elevated. So probably that person has a multiple myeloma protein that's IgG subtype, and the IgA is there a little bit low. The IgM is there also a little bit low. So then we break this down in what we call protein electrophoresis. So we're breaking down that graph that we saw with the little waves, alpha, beta, protein, gamma globulins. They're all here, but now we have numbers. We know how much of these proteins this person has in the blood at the time of that blood work. And we see that the gamma globulin, that should be that wave like that with the long, large base, is 21.1, and it's high. And of that 21.1, 17.5, it's written here, monoclonal peak value. So of the 21.9 that you have here, 17.5 pertain to a myeloma number.
Okay.
You know what I mean? So that is, I don't need to see you to know that you very likely has multiple myeloma when I am able to look at this blood work and interpret it correctly. Because here I have a variety of proteins, so 3 major proteins, 3 major antibodies. Here I see this one is elevated. And then when I go down and I break down the blood work, I see that of the 22, let's say 21.9, 17.5 are abnormal. And then I say, and it's written monoclonal. So down here, we don't have it, but we have immunofixation, which gives me the name of the protein. So I think in the next slide we have it.
Okay.
So they say monoclonal IgG kappa, so there you go, IgG. Okay, so that's explaining to me that this reflects this.
Right.
Okay, so does that make a difference for you to treat? No, vast majority of times, but we do know that depending on the type of protein that your myeloma or pre-myeloma produces, this could give us a hint about disease progression, response to therapy, and things like that. Nothing that's, mathematical and, exact science, but it gives you sometimes some suppositions. Yes, and it's also important for you to follow up, because this is one blood work in one time, and we now follow our patients for 10, 15 years. So it's a lot of blood work that we follow to make sure that, things are correctly happening inside each one of us, right? Questions? Because I thought this would be the most difficult part. I don't know so far. Okay, or 2 questions? Yeah?
One thing that impressed me about LHSC is the speed at which, like before I see like Dr. Pua, an hour before I could go in and get the blood screening done. And somehow in that 60 minutes, they can do that much work, which used to take many, many days.
Yeah, it's not that it takes many, many days. You're lucky, because I do clinic on Wednesday, and Dr. Pua, Dr. Lamb do on Thursdays and Fridays. So that blood work only runs on Thursdays and Fridays. So all my patients only get blood work the following week or the next visit. So me, Dr. Bargy, Dr. Foster, we don't have real-time results, and we're usually 1 visit behind. So what I do is I tell my patients, come the week before the Thursday. So if you want to know real-time results, because then we'll have only 1 week of gap.
I assume a lot of that's automated.
It is mostly automated, yes, but you still have to have a technician, yeah, working and getting the samples, putting the samples where they need to be. And even though the machine gives you all the interpretation, they still double check. So they do cross-checking, and sometimes more than one technician to make sure that the results that are being released are accurate. Yeah.
Our son works in hematology down in California, but they're working towards the use of a lot of AI tools to do a lot of this.
A lot, yeah.
Literally within
And interpretation, not only with this, but also checking into CT scan results, merging with this, and giving, it's been really cool, and giving actually prognosis, getting molecular results with the type of protein the patient has, with the type of bony lesions, if the patient has bony lesions, and giving a prognosis in terms of, oh, this patient will be able to stop the treatment, continue the treatment. I think it's gonna get wild, and I hope wild in a good way. I just hope I have enough brain cells to understand all that. That's about to come in the next few years. Yeah, but, and then when we continue with the blood work here, then you can see that we have kappa and kappa lambda ratio. So do you guys know what that is? Lisa, oh, Lisa, you had a question too.
Yeah, and I'm really interested in that part, but I know when I look on, I think it's Connect My Health now, whatever the new, it often will show abnormal, and that really throws me, even though I then, you know, everything's okay, I find out after. But when it says abnormal, it's just a piece of the picture, right? And
Yeah.
I think it can really concern you, and you wait a few days to see if you hear anything if you don't have a clinic appointment.
Yeah, yeah, and I get where you are, right? It's always anxiety provoking to see when the color in the in the presentation there is wrong, or if it says abnormal on the side. So there's lots to talk about the kappa lambda assessment. So the kappa and the lambda, so our myeloma cells, or our antibodies, I should say, they are always made up of two parts. One part that we call heavy chains, and another part that we call light chains. So when you look at the G, A, and M up here, those are heavy chains, and the kappa and the lambda are light. So you can see that this immunofixation tells me that this myeloma protein is IgG kappa. So it's a two-component, it's a two-part antibody, okay? Just like if you have the head and the body, okay? So they're together there. But we break them down when we do the blood test. So this pertains only to kappa and lambda, but the kappa and lambda that we see here are more like the IgG and not like this one. This one is the selected myeloma protein. Here we have everybody grouped together, okay? So in the kappa we have a level that's roughly up to 20. And you see this fellow here has almost 5,000, right? More than 4,500. So this is a very elevated level. So if I would be looking at this blood work for the first time and I had just this portion here, I would say, oh, this guy probably has multiple myeloma. This person needs investigation, right? And then the ratio is simply the math, right? So it's the kappa over lambda, so one divided by the other, and here you have the ratio. The ratio is usually between 0.1 and 1.65 for somebody that has a normal kidney function. But sometimes when we have renal dysfunction, this ratio and these numbers may be higher than what we call normal cutoff, right? So if you are a person that naturally has a kidney function of 40%, even if you don't have significant amount of protein, monoclonal protein or myeloma protein, in that you're not producing a significant amount of monoclonal protein, your normal kappa may still not be fully filtered. filtered by our kidneys because your kidneys don't work well anyways. So we will see higher levels, but the ratio is usually modest. The ratio is usually around 3, 4, usually not in the hundreds like this one. So when the ratio is in the hundreds, then we worry. So how do we know how much of this is myeloma? Then we have to do a 24-hour urine. When we do the 24-hour urine jug, we're looking into three major things. Number one, do you excrete enough albumin or too much albumin? That's a very important question. Number two, of all the proteins you're excreting in 24 hours, how much is albumin and how many of them are monoclonal myeloma proteins? And then when you know that you have monoclonal myeloma proteins, what type are they? Are they an IgG kappa like that one that we put there, or are they another type of protein? So that's what we look at, and that's what we look for when we ask for a 24-hour urine. Because a 24-hour urine we are able to do this breakdown, and then we can look exactly at what is what. Okay, but we don't do it all the time because it's a nuisance to be peeing in the jug for a whole day, right? So yeah, and so this one serves a very good purpose to give us a very good idea of what's going on from a myeloma protein standpoint. So this is really the standard of care now for day-to-day follow-up of myeloma, especially myeloma treatment outcomes, right? So how well are you improving with the treatment I'm giving you? We use this one, okay? Yeah.
Next one.
Can you keep going?
Nope.
There you go. So these are the normal levels, okay, so the reference range of the kappa and the lambda for you there, and this is what we use the most. Some of you have noticed probably over the past couple of months, I don't know if you noticed, Lisa, that these cutoff values here have been different, sometimes very high. So if you put the next slide.
Okay.
This is a very busy slide, and the writing is not very good. This one is not so relevant. I just wanted to show this one if we had a better view, because this is a study that was performed in Iceland. It's called iStop-MM. It's a study that has over 75,000 people from Iceland, all volunteers that have been followed over the past 15 years so that we can understand the natural history of myeloma. So we have a certain number of MGUSs, certain number of myelomas, and of the MGUSs, which I think we have, the numbers are, I'm missing the numbers now, but I think, yeah, of the 75,000 that we have, I can't remember the proportion, I'm sorry, I'll leave that, I won't make up numbers, but they were able to assess persons that had an underlying renal dysfunction, and they noticed that depending on the person's age, and as you were mentioning, the GFR, the eGFR, which is the filtration of the kidney, so what's the percentage of functionality of your kidneys, that those could actually be better assessments to tell you if your kappa lambda levels and your kappa lambda ratio should not be within that interval of 0.1 to 1.65, but different. So you can see here, for instance, somebody of any age that has a kidney function that's less than 30%, their normal kappa is 11 to 265 instead of the usual, if you put the previous slide,
Oh, yep.
3 to 19.4.
Oh my gosh.
And then if you look here, for instance, the lambda, 5.7 to 26. So if we put the next one for the lambda, if you are less than 70 with a kidney function of 60% or more, then you have 5.9 to 36.7, so pretty close, right? Because there it's around 20, 26, I should say. But if you have a kidney function between 30 and 40%, 44, you're 8 to 73. So that decreases. And we've been seeing this in our lab, but I'm gonna have a conversation with our colleagues because I think we need to go to a consensus, because this is for MGUS. This is for the pre-myeloma stage. This is not for multiple myeloma. So I think that for multiple myeloma, we need to use the standard, which is in the previous slide. So don't panic if you see that, oh my gosh, my normal is up to 170 now, and before it was just to 1.6, or 26 or 19. So don't worry, because we're looking into this. The Canadian Myeloma Group is looking into this as well, so that we can get to a consensus, a Canadian consensus, along with what's happening around the world. But these numbers can be confusing, and when we throw in age and several levels of kidney function, it can be complicated for the patient and the caregiver to try to understand why my normal is not your normal, right? So don't worry about that. And I think this is what I had. I don't know if I have anything else. No. Those are the major tests. So every time you come to see your myeloma doctor, we will have request these tests and more, but the others I didn't bring because they're not really of interest for you. So these are the basic panels that we request every time we see you in clinic. And that may be of interest to you to ask your doctor what the results look like.
Great.
Questions? No?